value of Trimetazidine in post-invasive care. So it's my honor to invite our co-chairman, Tommy Fairman, to give the last word. Over to you, Tommy.
Thanks, Paul. Good morning, everybody. So, like Paul mentioned, that my talk is not about the stand rule or other sophisticated things. So, I talk about pharmacotherapy. Even I know that most of you are working with labs, but don't forget you are still clinical cardiologists. You meet the patient in the clinic and they complain everything in the clinic, not in the lab. So I think it's really important to know regarding the pharmacotherapy, especially when you're dealing with the angina in the clinic. So the topic will be beyond factorization, the value of Trimetazidine in post-invasive care. So this is a disclosure, this is a topic sponsored by BT Nova. But anyway, just to remind that the CVD prevalence, especially in Asia and also, of course, in Indonesia, most common patients know that they have coronary artery disease when they already have a heart attack. So, and then the other, unstable ejection. Most of the patients know when they have a heart attack, get admitted to CCU, then they know. So this is the data, old data, 15 years ago, that in Indonesia, the number of coronary artery disease is still increasing. But we know after 2014 we have what we call it the universal health coverage. Every 100% of the Indonesian population covered by insurance. So maybe the number of cardiovascular disease will be double or even triple. So in these 2 days we learn also among patients with ACS coming with the lab, the number of multifactorial diseases, the range is between 44 to 65%. So if you look at the global data from the race registry, China registry, complete trial, you can see in global the number of multifactorial disease is around 50 to 58%. What about in Indonesia? We have some data from Makassar, South Sulawesi, in Jakarta, and also Sidoarjo, East Java, showing is almost the same that the multifactorial disease is 44 until 65%. So we know based on the guideline and also from Indonesian guideline, we adopted guideline from the EAC. Some of especially for the STEMI patient with multifactorial disease, so the patient should do a complete vascularization within the 45 days. But what about the real data, real world? Actually, it's not that easy. It's really depend on how the reimbursement system. It's really depend on how the health system flows to you, and of course, in Asia, it's really depend on the patient and family willingness. This is the data I took from the meta-analysis last year. Maybe not really updated. Then it can show that, let's say in Italy, for the subsequent state PCI, the patient can wait almost 2 months. Means that maybe the patient is in chest pain because the patient got incomplete vascularization. Egypt, maybe slightly better. Russia, Italy, Romania, and Switzerland, surprisingly, they mentioned about 7 days. What about in Indonesia? Well, we have a universal health coverage, what we call it BPJS. But the problem is the paperwork is really sometimes not really good. So if the patient got one PCI, so it needs time to do the second one because the patient must go for another referral letter, and after the patient got the referred hospital, there is some waiting line. It's really depend. A, B, C, D is really depend. In my hospital type A, the waiting line surprisingly is less than now. Because almost all of the, let's say, easy PCI already done in the type B and type C. So the waiting line in type B and type C is much longer than Harapan Kita in cardiac center right now. Because all the patients should go there first before they send Harapan Kita. So this is a really interesting phenomenon. So what about the big data? This is the Ultimaster registry. We also involved in the Ultimaster registry in real world data. Actually, in the ACS with multifactorial and non-STEMI patient, you can see 53% actually got a complete vascularization. This is real data. Not all the patients willing or got complete vascularization. Means that there's a chance the patient come to your clinic and still have stable chest pain. So we're not talking about ACS again, but stable chest pain. So this is the typical Asia. I took from the Chinese Medical Journal. It's almost the same with Indonesia. Not all patients are willing to have procedure. Is this right? Especially for the second one. One, this is the fear of the procedure. Sometimes the first procedure get them traumatized, procedure of high risk, and then there's a typical Asian preference for alternative treatment, herbs, we call it Indonesian jamu or whatever, and then they change the medication and refuse to get another PCI. And then also maybe the Chinese being American also the one reason he refused to get repeat PCI, I don't know why. So let's again. So we go to the patient go to the clinic and meeting you. So this is the time to get the combination between anti-ischemia, anti-angina. It can be between calcium antagonist, beta blocker, or nitrate. I think that's the most common medication in the clinic, and the blue boxes showing the preferred indication for those of the medication, but the red boxes showing it should be contraindicated. But the problem is, if you choose a beta blocker, a CCB or nitrate, we know that all the medication have some hemodynamic consequences, not all, but still we have to pay attention that, let's say for beta blockers, it cannot be given by a patient with bradycardia or asthma. Calcium channel blockers is very common in Indonesia, patient coming after 1 or 2 months with leg swelling, angioedema, and nitrate also with a big headache. Sometimes patients refuse to take the nitrate because of the headache. So that's why we need another alternative anti-ischemia, anti-angina, or anti-angina, let's say like Trimetazidine, which no effect of the hemodynamic, no bradycardia or whatsoever. So just to remind you, this is biochemistry that we learned when we in second grade of medical university. We know that in cardiac metabolism, to get one ATP to myocardial depend on the two pathways. One fatty acid metabolism is got responsible for 2/3 of the ATP, and 1/3 is coming from the glucose metabolism. And then in ischemia, on the right hand boxes, you can see that during ischemia, both of the pathways will be reduced, and the need for the oxygen even increased with the ischemia. So we need a pathway that more efficient. We call it efficient because the glycolysis only need 12 molecules of oxygen. Compared to the free fatty acid metabolism, it will need double or even triple oxygen molecule. So that's how it works. You know, we need to Trimetazidine because it blocks what we call it the enzyme acetyl-CoA acetyltransferase or 3K18 enzyme to shifting the metabolism from the free fatty acid metabolism to glycolysis. This is the animation showing, and this is our colleague from Turkey showing that comparing to the Tyson, both of medicine efficient to reduce the number of angina attack per week and also nitrate consumption. What if we combine between Trimetazidine and the Tyson? It can be better. You can see it's significantly going to increase in angina attack in 1 week and also increase exercise time before ischemia onset. This is an interesting study also showing that after the PCI, you know that FFR should be increased. That's very logic. But surprisingly, they also measure what we call the microvascular obstruction by putting pressure wire and measuring the IMR. This is the parameter for microvascular obstruction. And in the patient blood, Trimetazidine, the IMR is surprisingly better. They not really know what happened. That might be also Trimetazidine increasing electro oxide production and the level of the microvascular. This is also showing in the AMI, post-AMI patient got Trimetazidine has a better submaximal exercise test. And this is really interesting also from Russia. Patient after MI and have multivessel disease and incomplete revascularization, but almost the same with the initial problem. So after 1 year, they see that the heart endpoint is reduced 18% compared with the control of the placebo. This is type 2 diabetes patient. It's also important. And you can see that most of the patients in this study have a functional class 2 or 3, and then after they give Trimetazidine, 70% of them go relief, and then only 30% remain in class 2 or 3. This is also interesting that they put a patient with Holter monitoring for 24 hours, and they mentioned that the patient group of Trimetazidine has a significantly reduced the type of silent ischemia, showing by ST depression in the Holter monitoring, and also reduced the number of silent ischemia. This is a triple study also comparing Trimetazidine with metoprolol, 50 mg twice daily, and showing also that the patient that Trimetazidine has even better angina comparing with the metoprolol. This Korean registry showing that it also has a good outcome in terms of death in patient with the Trimetazidine. But we also must be fair. The latest one, RCT comparing Trimetazidine and placebo in the patient ACS. This is the trial, the very fair trial, very nice trial, but not statistically significant. Why? Maybe because it's routinely given to all patients, even the patient not got angina. Only 18% patient get angina. That maybe in subtle analysis, they still think that maybe it's still valuable in post-ACS patient if the patient still have angina, but not every patient. Patient is asymptomatic, maybe it's not in place for Trimetazidine. So this is my last slide. Just to remind you that ACS and multivessel disease affecting 40 and 65% patient look like it's happening globally. And then after PCI and especially in complete revascularization, angina or ischemia may persist. And we have also some drugs already proven, like metoprolol, and cellulitis or nitrate, but we still think need additional if some contraindication in the growth like Trimetazidine. I think this is my last slide, Paul. Thank you very much for your attention.
Thank you very much, Tony. We are a little